presented by a special speaker from a very beautiful city, none other than Dr. Shyam Kaji Maharjan, Associate Professor, Clinical Coordinator, BDS Program, Department of Prosthetics and Maxillofacial Prosthetics, People's Dental College, Nepal. He is the chairman of Dental Academy, Nepal. Then he is the consultant president from ARS Dental Clinic, Nepal. He has done his master's in orthodontics and maxillofacial prosthetics from People's Dental College and obtained his fellowship from International College of Dental Education. He was awarded with Parivartan Saga 2017. Our honorable chairperson is Dr. A.K.M. Azizul Haq, ex-professor, Department of Prostatics, Dhaka Dental College. We are very glad to announce our chief guest of honor, Professor Dr. Abul Kalam Azad, Head of Department of Prostatics, Medical College, Dental Unit. Our moderator is Dr. Anupam Poddar, DDS, MS, Associate Professor, Department of Periodontology and Oral Pathology, Dhaka Dental College. We are very delighted to express that now we have here some national and international maxillofacial prosthetist, dentofacial. Maxillofacial surgeon, Associate Professor and Vice Principal, Shyam Dental College, Pune, Dr. Mahmoud Sajidin, Associate Professor, Department of Orthodontia, BSME, Dr. Pradeep Dash, Associate Professor, Sheikh Hasina Burn and Plastic Surgery Institute, Dhaka, Dr. Uday Goswami, Assistant Professor and Maxillofacial Surgery, Dhaka Medical College, Dr. Riyad Mahmood, well-known and private practitioner. Rajiv Boni, as Professor, Department of Prosthodontics, DSMNU. Dr. Nafiz bin Jamani, Clinical Lecturer, Department of Maxillofacial Prosthodontics, University of Science, Malaysia. Dr. Ashikul Vadut, Department of Prosthodontics, Abjad Dental College, Dhaka. Now, I would like to convey my session to my moderator, Dr. Anupam Poddar sir, to conduct this session. Thank you.
Thank you. Good evening. Welcome everybody in today's webinar session. Thanks Dr. Mehnaz and thanks a lot to Basic Dental School Bond for organize a very important scientific session in this COVID period. We all about lockdown 4 to 5 months. In this period, we got academic nutrition in different webinar session all over the world. We enjoyed very important sessions. We already marked about today's session with guest and hello শোনা যাচ্ছে hello
হ্যাঁ শোনা যাচ্ছে
guest and panelists. We have tried to involve multidisciplinary panelists for appropriate replacement by prosthesis of surgical removal of maxilla mandible as well as whole facial-maxillary region and rehabilitate the patient in a society. First of all, I would like to go to the today's chairperson, Professor Dr. A.K.M. Azizul Haq, ex-head of the Department of Prosthodontics, Dhaka Dental College, and also the President of Bangladesh Prosthodontic Society. He is trying to enrich Bangladesh Prosthodontic Society academically and research-oriented organization. We feel honored to make him chairperson of today's webinar. I am requesting to chairperson to say a few words about this session and also inaugurate this session.
Thank you, Dr. Anupam Poddar, who is working a good job as a moderator in this session. Uh, it's a nice moment. I am feeling proud to be and present as a chairperson of this session. In today's session and in this program, our speaker is a renowned prosthodontist of Nepal, Dr. Shyam Kaji Maharjan, uh, who is a learned person and a renowned uh, prosthodontist. Uh, he has come to Bangladesh for several times, inviting us and organizers of different professional bodies previously. So he is a good friend, and also Siam is a good fellow feelings when I, along with Dr. Anupam Poddar and Dr. Jackie Ajam, uh, 2018, when we visited Nepal, he showed a good hospitality for us and show a good fellow feelings. As he is a good friend for our profession, today he will deliver a nice and important topics. This topic is maxillofacial prosthetic rehabilitation, improving quality of life. I think this session, uh, uh, which one is delivered, which will be by Dr. Shyam K. Maharjan, will be nice one, and everybody will enjoy this session. Okay. Now I am requesting Dr. Shyam K. Maharjan to present his uh, presentation. Dr. Maharjan.
Okay, thank you, sir. Namaste to the respected chairman and chief guest, also the president of Bangladesh Prosthodontic Society, Ajit sir, and the moderator Anupam Poddar sir, and the whole panelist. So, with the permission of our chief guest, I would like to start with my presentation.
Yes.
Permitted. Okay, Maharjan, permitted.
Thank you, sir. Can my slides are visible, sir?
Yes,
Yes.
yeah, okay. Everything is okay. Your speech
Okay.
and audio and video both are clear. Okay.
Okay. Thank you, sir. So today I'll be talking regarding the maxillofacial prosthetic rehabilitation. So how to improve the quality of life of the patient. So currently I am associate with People's Dental College, where I am an associate professor, and I work as a consultant prosthodontist in ARS Dental Clinic, and also the one academy we have, which is Dental Academy in Nepal, where we train the fresh dental graduates to build their technical knowledge. So namaste, assalamu alaikum to all. So I belong to the country, beautiful country where Nepal, and if we talk about Nepal, everybody says talk about the Himalayas and the natural beauties, and we have lot of temples also. So Nepal, especially the Kathmandu, is also known as land of God. And one other interesting part is, like, in Nepal we have the god to relieve any type of pain. Like, we have Kan Devta, means Kan means ears, Devta means God. Okay, if we have the ear pain, people used to worship Kan Devta to get relief of the ear pain. Same like we have Danta Kali also. Like Danta means that, Kali means Devi, goddess. Okay, so if they have any pain, dental pain, they worship the Danta Kali temple. So like that, uh, s- uh, in center of the Kathmandu, we have a tooth relief god also. Like if uh, any people they have this toothache, they just go to this place, toothache god, and they just hammer the coin with a nail in the big log, and they believe that after doing this, dental pain will be relieved. So there are the many traditional beliefs are there regarding the dental treatment in Nepal. Like even if you go to the remote part, like not the dentists, okay, so the other people they are doing the extractions because of the lack of manpower in the all part of the Nepal. And sometimes these scenarios shows that like there are many cases that may be untreated if they have the oral cancer. So the people they may be presented to us when they have the massive growth of the tumors. So patient may be presented with the small, moderate to the huge tumors also. So uh, and that will make the challenges make more challenges while treating these type of the patients. So when we see the status means like from the International Agency of Research on Cancer, they said 18.1 millions of new cases globally. We can found the globally 18.1 million cases per year, and death is around 9.6 million of the cancer patients. So if you see the status of Asia, we have 57.3% of the cancer cases per year, where death rate is about 7.3%. And even in 2020, US has estimated about uh, 18 lakhs 6,950 new cancer cases, with the death of around 6 lakhs of the death cases. And among them, in US also, they have estimated about 53,000 of the oral cancer cases, with the death of around 10,000 of the cases death with the oral cancer only. So this is the status. This is the estimated uh, data from the American Cancer Society. So even WHO said that 6 lakh 57 cases of the oral cancers can be are estimated in 2020, with the death of around 3 lakhs and 30,000 cases. And mainly the oral cancers sites are lip, oral cavity, nasopharynx, and pharynx, with and the risk is more in central South Central Asia due to risks of high exposure risks. And if there is a tumor or cancer, like most frequent treatment modalities of those diagnosed cases are the surgical interventions. So these cases are treated surgery. Most of the cases are treated surgically, and after the surgical treatment, there may be the defect created. So surgical intervention will create the surgical defects that results in the functional, aesthetic, social, and or psychological impairment. So patients may be psychologically, socially, aesthetically, and even functionally deprived after the surgery. Because in case of extensive surgery, like in this case, the maxillectomy with exenteration of the orbit was done. So the defect that start from oral cavity to the orbit. So they have a lot of problem associated with functional and the psychological. So sometimes patient may be untreated like this with the defects, and sometimes the patient, they try to hide their defect with these patches, or patients, they live like the pirates with these badges on to hide their defect. In some cases, like in these cases, this was also the case where a maxillectomy and orbital exenteration was done, and the defect that was tried to recover with a frontal rotational graft, which again create the defect in the facial regions. So to treat these conditions, we have one emerging, it's like emerging field in this South Asia, where we call it as a maxillofacial rehabilitation. So maxillofacial rehabilitations can be done with the surgical reconstruction as far as possible. If not, then it will be done with the prosthetic rehabilitation. And to have the successful rehabilitation, it should be approached in multidisciplinary way. So a successful prosthetic design for the functional restoration of the maxillofacial defect that will utilize the remaining bone, soft tissue, dentition to maximize the support, stability, and retention of the prosthesis. So it gave a big challenge to retain the prosthesis, because a lot of orofacial structures that has been removed because of the tumors of those areas. So to get the retention, stability will be the big challenge. And of course, to gain the aesthetic and function is also the challenging part during the rehabilitation of these cases. So treatment success, that depends on these three factors, like patient factors, surgeon factors, and the prosthetic rehabilitation part. Like the patient's factor means the extent of the lesions, with the extent of the how extensive is the lesions, or in what stage patient presented to the clinic for the treatment of those cases. And usually the surgeons, oral surgeons, even ENT surgeons, okay, are the one who usually resect, do the treatment of these tumors related to the maxilla and the facial regions. So the way they do the resections, that also plays the vital role. Means during after the surgery, we need to do the prosthetic rehabilitation. So the defect will shows the prognosis of the prosthetic rehabilitation. So like while doing the surgery, if the surgeons are more conservative and they try to conserve the more tooth and the more bone, then it will be more easy during the prosthetic rehabilitation. So it will become the team approach for the rehabilitation of this case, where the maxillary prosthetic team and surgical team should work together. So especially the coordination can be done pre-operatively for the pre-operative management, and the surgical modification can also be planned during the surgery with the coordination. So during the pre-operative management, what we can do is, like if patient have the poor oral hygiene, we can go with the oral prophylaxis. If they have the deep caries, then we can go with the management of the caries teeth before the surgery, because after the surgery it will be more difficult. Okay, if any tooth need to are hopeless, then we can also go with the extraction of the hopeless teeth, because in many cases we need to go for the radiotherapy. So after the patient goes for the radiation therapy, it is always high risk of the osteoradionecrosis. So, and it's a difficult to plan for the extraction, or we have to wait for a certain time. So extraction of the hopeless teeth should be planned prior. And of course, the fabrication of immediate surgical obturator, that will help a lot to recover the patient immediately after the surgery also. So how we can fabricate the immediate surgical obturator? Like if the patient present prior to the surgery, so this is a case where there is the uh, carcinoma of maxilla. So the patient was referred before the surgery. So we make the impression, we do the cast modification, and we prepare the surgical obturator. So this is the surgical obturator. So after the surgery is done, so after the maxillectomy was done, so we plate the surgical obturator, and we it will help to put the dressing also. Like after we place the surgical obturator, hold the gauze pack, this will act as a base to put all those pack before the suture was done. So the suture was done. So this picture is immediately after the surgery. So this is immediately after the surgery, and this is post-op after the 1 week. So with this immediate surgical obturators, so patients healing response is very good. Like before uh, this immediate surgical obturator, before we plan for immediate surgical obturator, patient has to feed with the nasal tube, because the patient will have the many difficulties to feed from the oral cavity. So if we could fabricate these surgical obturators, especially in a surgical obturator, the healing response and the patient response is very good. But the challenge is like we fabricate the these obturators prior to the surgery, and we do the modification, and the cast modification may not be exact to the resection what we do, the surgeon do. So the mode of retention will be the challenging part in this condition. So for that we can use the C class, Adams class, we can use even the ball class was used. Here the 3 type of class was used to get the retention. Okay. Or we can use this fitted label bow can also be used, where we can activate the U-loop to get the retention. Or we can do the wiring also. Wiring also can also be done to retain the immediate surgical obturators. Or we can do the suturing. We can make the small vent hole in the obturators, and we can do the sutures also. But in some cases, the retention would be compromised. So even we try to use this titanium screw. Those were used for the fixation of the fracture cases. So those screw were used where the wire was placed and the obturator was retained. So these are the different modalities I have tried to retain the immediate surgical obturators in different clinical conditions. So next, we can coordinate with the surgeons to modify the surgical to have the surgical modification so as to enhance the prosthetic prognosis. So normally what the surgeons prefers are to do the complete maxillectomy through the midline. So it will be more easy to have the complete maxillectomy through the midline. So while we do the conventional total maxillectomy, so in this case, this midline will be the fulcrum line. So in these conditions, when we fabricate the prosthesis, so this will act as a fulcrum line, and it will be more easy for the prosthesis to lose its stability. So it can the stability will be maybe less in this case. But if possible, if we can ask the surgeons to at least conserve few tooth in the site of resection and resect the defect in this way, in this condition, when we fabricate the prosthesis in this area, this will be the fulcrum line. So the fulcrum line will be more towards the resected area, and the stability of the prosthesis can be enhanced in these conditions. For example, in this case, initially the midline incision was planned, and we asked the surgeons at least to preserve any teeth if possible midline. So the central incisor was planned to save in this case. So after the resection, central incisor was planned. So in this case, when we fabricate the prosthesis, the prognosis of the prosthesis was very good because we have the additional support and we change the fulcrum line. Similarly, if the patient has defect in the anterior region, so if we could save few teeth on the palatal aspect, it will be more easy and more beneficial for the patient to get the more stability. For example, in this case also, there was a lesions in the premaxilla area, in the anterior area. So we asked the surgeons to shave the most posterior teeth and do the resection in this case. And when we fabricate the prosthesis, so we can see the prosthesis, so the retention was very good in this case. So as we shave even a single teeth in this case. But it will be very challenging to the surgeons to do the resection in this way. So the surgeons usually say that they have to spend at least 2 more hours to conserve a single tooth. So regarding the site of resection also, we can change the plan, like usually this interdental area, the surgeons prefer the interdental area for the resection because it is easy to engage the saw during the maxillectomy or during the resection of the bone. But we could ask the surgeons to extract the teeth in the lesion and do the resection through the socket. Then we can have the septal bone preserved and the adjacent tooth will be preserved. Like in this case, the resection was done through the interdental area and the root was exposed, and ultimately the prognosis of this tooth was altered. And in the due course of time, we have to lose these teeth. So, but if we do the resection from the socket, so we will have a bone, and we will be able to shave the tooth. So we prefer usually we ask the surgeons to do the resection through the socket rather than to do the resection from the this interdental area. So next is the most common case are the mandibular resections. There are a lot of case of the mandibular resections, and I feel treatment of the mandibular resection is more difficult rather than treating the cases of the maxillectomy, because in most of the cases, complete mandibulectomy are done, and like this X-ray, like the complete mandibulectomy was done, and gradually these jaw shifted to the defect side, and the facial deviation can be seen, and occlusion will not be in a proper, and the patient will have the aesthetic as well as the functional deformity. So in this case are a bit more difficult because to rehabilitate we have no any support, and if in this condition this reconstruction can be done, it will be more easy. But in most of the cases of this carcinoma, patient has to undergo with the radiation therapy. So during the radiation, when patient goes to the radiation therapy, the healing will not be proper, and most of the time this reconstruction even fails. So if the patient has to undergo the radiation therapy, this reconstruction can be difficult with this titanium mesh. if patient has not need to go with the radiation, in those conditions it works better. Or sometimes we can ask the surgeons at least to do the marginal hemimandibulectomy, like the marginal bone was saved if possible. So in this case, it will have some support to will have some support for our prosthesis. So it will be more better. Or if this type of work can be done, it will be the excellent. So in this case, marginal mandibulectomy was done, and it was reinforced with titanium mesh, and implant were placed for the prosthetic rehabilitation. So this type of artwork, so it works more better than the before condition before I showed before. Uh, we can also improve the quality of life post-operatively with a few processes, like we can improve the post-operative life with a delayed surgical obturator if patient present after the surgery, or with the interim prosthesis if the patients are during the healing phase, or with the definite prosthesis after the complete healing. So like if the patient present with after the surgery, so in this case it is very difficult to make the impression. So patient will have the huge dressings, and they come with the NG tube. So the making the impression is very difficult part or challenging part in these conditions. So we usually prefer for the immediate surgical obturators, but sometimes patient may not be available for before the surgery. In these conditions, we have to go for the delayed surgical obturators. But in this condition, we will exactly duplicate the defect where it will be easy to fabricate the obturators. So in these conditions, we can fabricate the obturators that fits nicely in the defect area if we compare with the immediate surgical obturators. So if patient has to go for the radiation therapy, in those conditions, if the patients need some aesthetic because of the huge defect, they demands for some aesthetic, then we can add some teeth, especially in the anterior area, so as to have the interim prosthesis. So if the patient is in the healing phase and the immediate or the delayed surgical obturator that doesn't fit, and patient wants the aesthetics, we can have the interim prosthesis before we deliver the final prosthesis. So in this case, we can have few anterior teeth so as to give the aesthetic, but not the posterior teeth. Or we can, if the patient present with a complete healing, we can go with a definitive prosthesis where we can have the complete obturators. That may be the hollow bulb, especially the hollow bulb obturator we fabricate, so as to improve the quality of life. So these are the different conditions where we can improve the quality of life post-operatively, and we have discussed the area where we can work pre-operatively for those patients, CA patients, tumor patients, to improve the quality of life or to enhance the prognosis of the definitive prosthesis. So after this, I'll go for a few clinical case presentations where we have done the maxillofacial rehabilitations. Okay, so we'll see the different case, like one with the maxillary obturators, with the maxillary defect, with the mandibular defects, with the reality of the huge tumors, ocular, orbital, and the this combined defect, multiple defect, facial defect. So let's start with the first case. So this case was presented to my department after the surgery. So surgery was done, and even delayed surgical obturator was delivered to this patient. But patients have severe pain, and this we can see the facial features, how the patient present, and that definitely represents some sort of pain. And patient was inserting her fingers in the external auditory meatus to show the pain, like she has a severe pain in this area. So when we examine these patients, patient has done the maxillectomy and the obturator was delivered. So in this case, what was the problem is that this obturator was delivered because occlusion was not proper. So occlusion was not proper. So we modified the immediate surgical delayed surgical obturators, and the occlusion was this occlusion was kept in proper proper occlusion. Okay, so now these patients can occlude. So before she cannot, because the height was raised, so she has a temporomandibular joint problem. So after that, we wait till the complete healing. So this is the conditions after the complete healing. So after that, then we plan for the maxillary obturator and cast parcel in the lower arch. So in this case, we plan for the hollow bulb obturators with the cast framework. So this was the cast framework. The trial was done, and the correlation was done and trial. This is the during the trial phase, and this is the final obturator we fabricated for this patient. So this is the photographs shown after the insertion of the this obturators. So this is the initial defect, and this is the photographs after the post insertion of the this obturator. So in this case, it was properly rehabilitated with the obturators. So so this is during the occlusion. We can see the proper occlusion with the obturators. So this was the initial case patient presented to us. So patient left smiling after the rehabilitation with the maxillary obturators. And it is always good to see the long-term follow-up of these cases. So this was case done 7 years when I am doing my post graduation. So the patients came a few months back before the lockdown for the follow-up. So it's very good to see the this maxillectomy or the tumor patients in the follow-up. And sometimes it becomes so disheartening that we lose a lot of patients after the surgery, and even we could not able to do the definitive restoration of these cases. So this was one case. So the next case, this is a case where the mandibulectomy was done, and a patient used to wear the masks. He is reluctant to remove the masks because of the facial defect that was created after the this mandibulectomy was done. So we plan to have the mandibular prosthesis in this area. So here the marginal mandibulectomy was done, and the axillary graft was placed, and even the distal tooth was preserved. So this case was easy, actually the very easy case of the mandibular resection. So cast framework was fabricated, it was tried, correlation was done, trial was done, and this is the final prosthesis we achieved for this case. So this is the smile that we can able to give to the patient. So after the insertion of the prosthesis only, he actually removed the marks. So this was the case of the rehabilitation with the mandibular defect. So the third case, so this was the one case, a huge case. So actually this was the case. The surgery was not done in Nepal. So I think around in 1997 or 98, this case was published in daily newspaper also, that patient was untreated with these huge tumors. So later on, some these INGOs, they noticed this case, and they took her to the German, and they did the surgery, and she's doing well till now. 2008, I think, around 2008, she had some problem with the prosthesis. Then I came in contact with her around 2008, and since that I'm taking care of her. Okay, so and even I'm able to talk with the surgeons who did the surgery in the Germany. So he sent these pre and post photographs. He mailed me, and even when he came to Nepal, I am able to meet him also. Dr. Sethi did the surgery, yeah, from the Germany. So this was the case after the surgery, and this is the present conditions. Now she's doing well, and in this case, so this is the reconstruction was done. Here we can see the maxillectomy. This huge mandibular tumor was removed, and the marginal mandibulectomy was done, and it was reinforced with the titanium mesh, and even implant was placed to get the retention of the prosthesis. So this was the good. I always say the think that this was the very good art of work that was done around around 1998 around. Okay, 1998. Okay, uh, uh, and it was referred to us because she has the peri-implantitis. You can see the all inflamed tissue around the implant. So implantitis. So at this particular time, I'm able to treat this peri-implantitis. So it was treated, and it was so here in this second picture we can clearly see that the inflammation has reside, and some sort of recession was there, but some recession was there, but we are able to treat the peri-implantitis. And later on, around like these were the mandibular prosthesis. These were the mandibular prosthesis. So they have the like precision attachment were made, and even some locking system was there. Locking system was there. So they he can just insert this lock to retain the prosthesis. And later on, she again reported to us with the inability to chew. When I looked with this occlusion, so the occlusion, the teeth were where, and it was shifted to other side. So we can clearly see the slight shifting of the prosthesis and the wear of the prosthesis. So even though I do not have such technique to fabricate the beautiful prosthesis, I just try to make the lower denture similar to the conventional overdenture we do. So, but this denture works a lot, and it fits properly, and patient was again able to perform the function with this prosthesis. And this is the photographs uh, taken after delivery of this manual prosthesis, refabrication of the manual prosthesis, and she is happily using this prosthesis for the function from maybe from last 1.5 years. So this was the case, and fourth case. So this was the case of this ocular prosthesis. He had an accident, car accident, and the piece of glass was inserted in his eye, so he lost his eye along with the vision. So the impression was made by using this stock trays. We have prepared the acrylic stock tray for those cases also, or even we can have the impression. Even we can have the impression, primary impression alginate, and we can fabricate the stock tray and have the final impression also. So the stock tray was used, and the impression was made with a light body. So it was invested to have the wax pattern. So this was the wax pattern, and the trial was done in this wax pattern, and the iris orientation was also done. So this iris button will help to orient the this iris. So after that, we've initially fabricated this scleral blank with the white tooth color acrylic. So this white acrylic was used to fabricate the scleral blank. And to have this three-dimensional effect, we depend the area of the iris. We depend the area of the iris, and we paint with this acrylic color. So the acrylic color was painting was done with acrylic color. Then we can characterize with the vein acrylic, and it was again acrylized with this clear acrylic. So this is the final. This is the photograph after the insertion of the this ocular prosthesis. So it's very difficult to notice when the patients use their specs after they have this ocular prosthesis. So next case is this is a case of this orbital defect. Actually, he had the CA of base of the skull, and the surgery was done, including the exenteration of this eye. So patient was physically disfigured with this defect. So here we plan for the this spec retain orbital prosthesis. We make the impression. We have the wax pattern. We have tried the wax pattern. Then we did the acrylization, and we did the coloring also. So this is the prosthesis that we achieve after we do the by the acrylization. Okay. So after this, we plan to retain with the this glass. So it was the spec retain prosthesis. So we screwed and we use screw and glue to join this orbital prosthesis with the spec. So this was the final photographs after the insertion of the prosthesis. So in this case, we have fabricated the spec retain prosthesis. And the last case, so this was the case of the basal cell carcinoma of the maxilla, which was extended till the orbit. So the patient was referred immediately after the surgery. So this was the case after the surgery. So in this case, even the exenteration of the orbit, whole maxillectomy was removed. Maxilla was removed. So this was the intraoral condition. So here we make the impression and we fabricate the first delayed surgical obturators. So delayed surgical obturator was fabricated during the healing phase. So after he returns from the radiation therapy, we can see the conditions, how the tissue become after this intense radiation therapy. So we have to wait for a certain time, at least 6 months after the radiation therapy, we go with the definitive prosthesis. So after the patient was completely healed, so this was after the recovery, after the this radiation therapy, this was conditions. So then we plan for the global obturator in the maxilla, overdenture in the mandible, and the orbital prosthesis in the to recover this orbital defect. So this was the plan. Maxillo-facial obturator with the orbital prosthesis and the mandibular overdenture was planned. So first, to have the maxillary obturator, so we plan to have the like a hybrid type of this prosthesis. So we did the root canal, we prepared the tooth and have the coping in the remaining, because only 2 teeth are remaining in this case. So we fabricate the coping, over which we fabricate the framework, so that the fit will be proper and we can have the proper retention. And we fabricate the hollow bulb obturator. So this was the hollow bulb was fabricated. We did the teeth alignment and the prosthesis was fabricated first. Dental prosthesis was fabricated first. So this was the maxillary obturator, overdenture was fabricated. Then we plan to fabricate the orbital prosthesis. Okay, so this is the photographs only after insertion of the dental. So only the dental rehabilitation is not enough to rehabilitate this patient. So we plan for the orbital also. So we make the impressions along with the prosthesis, okay, because we want to attach the orbital prosthesis in the overdenture. So with the prosthesis, so we can see the extent of the overdenture here. So after that, we fabricate the silicon orbital prosthesis. So this was the silicon orbital prosthesis we fabricated. And the main challenge in this case was we have lack of material. So we have no precision attachment that can be used to hold 2 prostheses. So just this is the stainless steel press button. I tried to use this press button, male components was embedded in the obturators, and the female was placed on the this orbital prosthesis, and then it was we try to attach this. So these two were attached with this stainless steel press button, and the overdenture was planned. So this is the final prosthesis, combined prosthesis we planned for this case. So this is the photographs after the insertion of the uh, orbital prosthesis, obturator, and the overdentures. So this is the initial conditions. So this is the after the insertion of the prosthesis, and this is after the final delivery of the prosthesis, where and spray can be used to camouflage the border. So uh, uh, like even we do the pigmentation, we do the coloring of the silicon prosthesis. Exact duplication is very difficult. So we can use the specs to just mask the border of the prosthesis. So after that, I also plan for the ear prosthesis. So this was not my case actually. This was the case we have done in January, where we have Dr. Srinivasan from India. So he's a very good maxillary prosthodontist. So we fabricate the ear prosthesis. So this is the ear prosthesis we deliver to the patient. So uh, if possible, we have a lot of this orbital this auricular prosthesis case also, ear prosthesis case, and till now I'm not able to uh, do the good ear prosthesis. I tried because it was not so good, and after this attending this workshop, I'm planning to go with some digital workflow to have this ear prosthesis. So maybe if I got the opportunity next time, maybe I can show a few cases of the auricular prosthesis also. And in some condition, I have done this finger prosthesis also. So this was one case where the finger prosthesis was fabricated. So this was the finger prosthesis that was fabricated, and this was after delivery. The main challenge is the color matching is much challenging, because these colors that like the metamerism will be there. So if you view in the sunlight, if you view in the clinic light, the exact duplication of the color is a difficult part for us. So these are the new ventures I'm trying uh, to improve the quality of life of the patients with the finger and this auricular prosthesis actually. So I'm not done much cases of these. So in conclusion, this exploring the maxillofacial prosthetic rehabilitation has actually widened the horizon of the Nepalese dentistry, especially the field of prosthodontics. As I have, I am the one of the first batch PG from the Nepal. So at the time, we are able to get a few patients of the maxillofacial rehabilitation. So we got the opportunity to learn how to do the maxillofacial rehabilitation. So that knowledge I'm utilizing to rehabilitate the maxillectomy, this maxillofacial defect patients. And actually, we actually need the team approach for the rehabilitation of such patients, so as to enhance the quality of life of these patients. So we need a lot of approach. We need a lot of patients. Most of time, it will be the disheartening thing when the patient never turns after the surgical obturators. Okay, so what I would like to say is we'll be able to achieve the aesthetics. Okay, we'll be able to achieve the aesthetics with the maxillofacial prosthetic rehabilitation. So I would like to play a small video, like here in this case, the patient uh, he has the obturators. Okay, so we can see the sound he have. Uh, So this is the sound
clear
without the prosthesis. So after we insert the prosthesis,
लगाएपछि मलाई खान बोल्न एकदम सजिलो भएको छ
so we can see changes in the phonation. So we can have the nasal. So we can be more functional. So usually the nasal regurgitations are the main problem with this maxillectomy defect. So with the prosthesis, so we can prevent the nasal regurgitation also. And so the case I have shown, so she was so eager to chew by using that prosthesis. So at the time of insertion, she bought some food and tried to chew with the prosthesis. So she wants to try, she wants to masticate by using the prosthesis also. So we are able to provide the function to the patient with the prosthesis. So few years back, John Beamer was there in Kochi. So we are able to meet him and attend the workshop on the conference on the maxillofacial prosthesis. So the whole team of our department, along with a few other colleagues, who went to the Kochi to learn about this maxillofacial prosthesis, and even I have presented the posters of this orbital obturator and the mandibular overdenture case. So I would like to thank this basic dental school for providing me the opportunity, and especially the Ajit sir, Anupam sir, and I think it will be more beneficial to discuss with the panelists. I hope the whole panelists, they will have a more informative comment where even I can improve a lot during the rehabilitation of this maxillectomy, this maxillofacial rehabilitation cases. So last time when I was in Dhaka, I was able to visit BSMMU as well as the Dhaka Dental College. So I am very pleased to meet like Anupam sir, Ajit sir, who is now president of Bangladesh Prosthodontic Society. Even Dr. Rajiv is there from our panelists, and the whole team of the BSMMU. So actually, I was there for the presentation of the digital smile design in the International Smile Design Seminar organized by the Satar sir. But after I met Anupam sir and Ajit sir, so I was privileged to visit BSMM and Dhaka and present a few cases in that college also. So and I'm also pleased to see the team from Dhaka in Nepal in the Nepali Prosthodontic Society conference. So Ajit sir, Anupam sir, along with the Jeki, they came to Nepal with their team. So during the prosthodontic conference, and they visit my hospital also. So these are the memorable photographs with our respected sirs. So this is my team, whole department team. So Dr. Suros, he's my professor, and I have learned a lot from him. And he was the one who teach the maxillofacial rehabilitations also. And he's also from the Dhaka Dental College. I think he's a D21, I think. And Dr. Kansana, she's also from the BSMMU. She did the MS in prosthodontics from BSMMU. Now she's also the associate professor in my department. Okay, and all the other resident and interns. So this is my clinic, ARS Dental Clinic. So where I do the prior practice, and we have this Digambar. He's also the graduate from BSMMU. and maybe I have not kept the photo. Dr. Praveen, he recently graduated BSMM in surgery, and he's doing very well during this onco surgery. She works in one of the renowned cancer hospital in Kathmandu, and he refer a lot of case to me also for the maxillofacial rehabilitations. So Dr. Praveen is also in our team. He also is the graduate from the BSMMU. So I have one small academy where I usually train the juniors or the fresh dental graduates regarding the clinical dental practice. And even from last year, we have run the implant course also with this academy. And through the journey, through the whole journey, Dr. Regina, she's also the dentist, my wife. So she helped me a lot during to come to this stage of my career. So, and always the loving daughter is there to support us. So at last, I would like to say, like, this is the time whole world is in crisis. So we all need to take care, and we need to stay safe and work safely in our daily practice. So at last, uh, thank you. This is my. I have kept my email and phone number also. If you have any queries, you can uh, contact me in WhatsApp, Viber, or can also email, or you can also join me in Facebook or Insta, because I'm not present there. So virtually we can maybe the we have the panel discussion where you all can justify your queries also. Okay, sir. Thank you, sir.
Yes, sir.
Thank you, Dr. Shyam Kaji Maharjan, to discuss about the topics maxillofacial prosthetic rehabilitation, improving the quality of life. Shyam Kaji Maharjan is an associate professor, Department of Prosthodontics, People Dental College, Nepal. This department is run by Professor Saroj, who is a student of Dhaka Dental College, batch D24. Dr. Shyam also practiced in maxillofacial prosthesis and rehabilitation in his chamber named ARS Dental Clinic in Nepal. I think he discussed elaborately and nicely extraoral prosthesis, intraoral prosthesis, and finger prosthesis. Everybody enjoyed this. It was so much interesting and presentation with lucrative slides. Now the question and answer session. In chat box and Facebook page, we have some question. Now I details about the question. First question: how do you maintain the canine and molar relationship?
Yes,
Hello.
sir.
First question, Sham. How do you maintain the canine and molar relationship?
So, especially during the rehabilitation of this maxillofacial defect, uh, the area of the defect where defective area, that will be in less function until and unless we have the adequate support. Like if we are able to have the support from the implant, or if we have the adequate remaining bone or remaining tooth, only we can have the proper function. Otherwise we have to rely on the remaining side where the remaining tooth are present. So if you are talking regarding the occlusion in the defective side, so I prefer less functional until and unless there is proper support. So I think usually in those defect area we put will have less occlusion or the infra occlusion to maintain the stability of the prosthesis, and the patient has to function from the non-defective side. So there will be the if the question is regarding the this defective side, means we will have less, if possible we'll put in the group functional, Okay, so as to support the prosthesis, otherwise we will not take care of the canine guidance usually.
Okay, thank you. Another question: how do you ensure the shade of the skin? How do you ensure the shade of the skin?
Okay, to have the shade of the skin, we can have the this silicone shade guide is also available, sir. Silicone shade guide is available, but better way, like a better way is we can mix the silicone, we can add the stain, and we can uh, take that mixed silicone in the cellophane in the plastic sheet, and we can just take it in the patient area where we are fabricating prosthesis. So that's where we can ensure the shade of the silicone.
Okay. And another question: when will we take the impression in case of maxillofacial prosthesis? When will we take the impression in case of maxillofacial prosthesis?
So it depends, like if we are fabricating the immediate surgical obturators, so impression should be taken before the surgery and cast should be modified. If we are making the delayed surgical obturators, so 1 week after the surgery, so 1 week after surgery will be the appropriate time. 1 to 2 weeks after the surgery, we make the impression for delayed surgical obturators. If for the interim obturators, usually we fabricate the prosthesis after like the 3 months till we fabricate the definitive prosthesis, or for the definitive prosthesis to make the impression, the area should be healed. If patient has undergone the radiation therapy, we prefer actually to wait till 6 months, and after the proper recovery only we make the impression for the final prosthesis.
Okay. Another question.
অনুপম
Yeah,
অনুপম
দাদা।
এই তুমি যেটা বলছো ওইটা হলো যে বিফোর
ঠিক আছে, আপনি এটা পরে
সার্জারি
পরে দিবেন।
before surgery, if we take impression from the lesion, then after making the model we can make model surgery, and how much portion we have to cut or how much portion, that previously we have to decide that what will be the exact object we'll have to make. Before surgery we take the impression, then we make a model, and after model surgery we'll prepare the prosthesis accordingly. After that we go to the patient, and after patient surgery we will measure the measured obturator, then we place the obturator in position. This is the exact process. So thank you, Doctor, for your elaborating and very much fine presentation, and it's a good era for dental science that you have taken the decision for making various types of prostheses in maxillofacial region, and mainly we emphasis for this prosthesis is aesthetical purpose, then functional, and we have to preserve the main aesthetic portion of the facial region, then we go for functional. And my one inquiry is that how much time we have to wait for making any prosthetic rehabilitation, and suppose after maxillectomy, then healing time may be short, may be difficult in various, it depends on various process and various, suppose nutrition, age of the patient, nutritional status, and various others parameters we have to take for so overall how much time we will wait for this type of prosthesis. For making these types of prosthesis, how much time we have to wait?
So usually in a normal process, I usually wait for 6 months after the
6
surgery,
months.
sir. 6
Surgery.
months, okay, and
Usually
or
6
6
months
months after the post radiation.
post radiation.
Okay, Dada. I have a session to you. Please sometime later. Now I take question from Facebook and chat book. Another is question. Any role of microvascular surgery with free graft? Any role of microvascular surgery with free graft?
So, microvas. Okay, you say.
স্যার আপনি আপনি কোশ্চেনগুলো শুনে রাখেন, পরে যদি আমি আপনাকে তখন বলবো দাদা, তখন আপনি এটা বলবেন। ওকে,
আচ্ছা ঠিক আছে।
আপনি আপনি পুরো কোশ্চেনগুলো জেনে রাখেন, পরে আপনি ডিসকাশন করবেন, আপনাকে যখন আমি আলোচনা আনবো।
আচ্ছা ঠিক আছে।
First question from outside and Facebook and from chatting. Then panelist discussion and question. Panelist for panelist discussion and question. Next session. Okay.
Yes, Shyam. The question is any role of microvascular surgery with free graft? Any role of microvascular surgery with free graft?
Yes, sir. I got the questions. Like, if the defect can be always in most of the cases, the patient prefer the permanent solutions. Okay, if possible, like if the graft can be placed in those cases and defect can be closed, it will be more better. But usually what we found is after the surgery, usually in case of the maxillectomy, in those conditions whole maxilla will be removed, and even if we place the graft, it will have no bony support. Okay, so gradually it resides and the defect will be created. But if there is a bone, this microvascular surgery will work better, and it will definitely close the defects. So it depends on the cases, sir. It like in every cases we cannot go with a microvascular surgery.
Okay. There is another question. How you find CR before you do surgery? How you find centric relation before you do surgery?
Like in the usually in this defect, no, there is a less role of, I think, centric relations, because we have the opposing teeth. Like if we go with the maxillectomy, we'll have the remaining mandibular teeth and the some portion of maxillary teeth. So we have to occlude regarding the previous occlusion. But in case if we are planning for mandibulectomy, in those conditions, the mandible may shift to the defective side because of the muscle pull. So in those conditions, only we need to guide the mandible in centric relations. So in those conditions, maybe we can have the guiding appliance, okay, guiding mandibular guiding appliance to bring the mandible in the centric position.
Okay. Another question: can we place basal implant? Can we place basal implant?
To get the retention implant may be the best option, sir. To get the retention implant may be the best option, but in Nepal, till now, none of the implant were practiced to retain the maxillofacial prosthesis, sir. Till now, to my knowledge, till now, no case was done with the implant. But definitely, if we are able to place the implant to retain the prosthesis, it will be more better.
Okay. Another question: how to manage the scar tissue elasticity after radiation because it become harder? how to manage the scar tissue elasticity after radiation because it become hard.
Definitely, sir. Management of the tissues will be difficult after the radiation. Usually, after the radiation, patient will have these mucositis, inflamed tissues will be there. So that's why we have to wait until the tissue regain the normal form. So that's why usually definitive prostheses are planned 6 months after the radiation therapy. But the main problem will be the trismus is the main problem after the what I found after the radiation therapy. Lot of patients have developed the trismus. So to manage the trismus, we have the trismus appliance. We can have the trismus appliance. Or if not, we can ask the patient for the mouth opening exercise, or we can ask the patient to use the tongue blade to place in between the teeth and increase gradually till we achieve the normal occlusions.
Another question, what about zygomatic implants for maxillectomy defects? What about zygomatic implants for maxillectomy defects?
So, like I have already told, no, sir, implants, they are the very good options, sir. Implants, they are the very good options to have the to get the retention for the prosthesis. And the zygomatic implant, they have shown as a last resort of the retention to achieve the to stabilize the prosthesis and retention in the defect where the alveolar bone are not present.
The last question, how you check occlusal load on defect side and sound side? How you check occlusal load on defect side and sound side?
So usually, like if we have this total maxillectomy case, okay, total maxillectomy case, to have the load, it is a bit difficult because the whole portion that will be supported from the adjacent side only. So what we practice is we ask the patient to perform less function from the defective side, because to shape the to have the long-term prognosis of that prosthesis, if the patient perform the function from the defective side, the stress will be usually achieved on the adjacent tooth. So the prognosis, if the tooth are weak, the possibility of tooth loss is very high. So we usually ask the patient to perform the function from the remaining natural tooth side, and the adjacent teeth, usually in the defective side, they will perform less. It is not that they will not in function, they will be in function, but it will be not effective as the natural side, sir.
Okay, thank you. Now the schedule for panel discussion, we approaches to multidisciplinary panel members included maxillofacial and oral surgeon, plastic as well as cosmetic surgeon, dentofacial, orthopedic, prosthodontist, and also maxillofacial prosthodontist. I hope they discuss elaborately about the topics. They can add and give suggestion, make an asked question, who can new another idea incorporate. First of all, now I would like to request well-known oral and maxillofacial surgeon, Dr. Uday Goswami, who posted in a very important place in our country, that is Dhaka Medical College, as the assistant professor in oral and maxillofacial surgery department, to take part discussion in about today's topic. Dr. Uday Goswami.
Thank you, Dr. Anupam Poddar. Am I audible?
Yes.
Can you hear me?
Yes, sir.
Okay. Good evening to all, and thank you very much for the organizing committee and for inviting me. I feel very proud to be here. I will take the privilege to give thanks today's keynote speaker, Dr. Shyam K. Maharjan, for his nice presentation. I think he has discussed every nook and corner in maxillofacial prosthodontist. We know very well there are so many defects in facial region. It may be congenital or acquired. Acquired may be either trauma or surgical pathology, especially malignant lesion in the facial region. I have been working in maxillofacial sector for last 12 years. That's why I had to face many such type of cases, and we have to face different types of problems, such as after maxillectomy, what will be the immediate prosthesis. And you know, malignant lesion surgery and malignant lesion treatment is a multidisciplinary approach. And here, maxillofacial surgeon, plastic surgeon, pathologist, uh, radiologist, medical oncologist, and they have the important role. And I have little idea regarding the maxillofacial prosthodontist. And today I have learned too much from Dr. Shyam Kaji Maharjan that the maxillofacial prosthodontist has the vital role in case of oral cancer management. And in case of oral cancer management, as it is a multidisciplinary approach, we have to prepare our treatment protocol before going to surgery. And what will be the surgery, and what will be the reconstruction option, as well as what will be the processes. We have to take the decision before going to surgery. And our today's keynote speaker described it very nicely. He mentioned and everything, and he already shown us different cases which he has done. And here our renowned microvascular surgeon is present here. Dr. Pradeep is present here. He will say his sector. And now I want to say that in case of oral cancer surgery, we have to decide how far we can go, because if we want to clear the lesion, we don't have the option to compromise the surgery and to compromise any tissue. And in that case, we have to discuss with our prosthodontist and microvascular or reconstructive surgeon. And before going to surgery, we have to take impression, already discussed it previously. We have to take the impression of upper jaw or lower jaw, which will be treated. And after that, we have to fabricate any obturator, surgical obturator, which is inserted during or after surgery. And after that, the prosthodontist will introduce the interim obturator, and finally they use the permanent obturator. And I want to say that the maxillofacial prosthodontist has the vital role for giving the better management and better result of the oral cancer patient, and not only oral cancer patient. In case of traumatized patient who has lost some facial tissue or structure, they also need the prosthesis. And now I just want to say that we have to work together. We have to work together with the maxillofacial prosthodontist to provide the better management of our patient. And now
I have a query to our today's chairperson, Professor AKM Azul Haq sir. As I work in Dhaka Medical College, how can I get, or how can we get the maxillofacial prosthodontist in our institute to provide the maxillofacial prosthesis support?
Okay.
And I think
Sir will discuss later.
Aziz sir will
Aziz sir will discuss
give the
later.
answer.
Okay. Thank you.
Thank you, Anukumda, and thank you the organizing
Thank
committee for
you,
inviting
Dr.
me.
Uday. And now I invited to Dr. Mahmood Sadedin, very known academician as well as clinician, orthodontic and endovisual orthopedic field. Do job as a associate professor, orthodontic department, Bangabandhu Sheikh Mujib Medical University, Dhaka, to give some appreciation about today's topic and discuss about as a orthodontic have you role he orthodontics have you any role in maxillofacial defect treatment protocol.
Thank you, Anupam. And I want to thank today's chairman, Professor Ajit, AKM Ajit, and Shyam Maharjan. This word Maharjan, I don't know what is the meaning of it, but in Bengali, Maharjan means great achievement. And what you have done seems like a great achievement to me, because just doing the surgical part for tumor surgery or a trauma is not enough, because if you have to ensure a normal life to that person, and in that case, your this type of things, these are quite new, because previously prosthodontists, we used to think that it was dealing with only replacement of dentures and other things, but the way you showed us, like replacement of ear, eyes, even with the replacement of fingers, it seems that you have a broader field and you are doing a great job. I was quite keenly listening to your lecture just to know if orthodontists have any role in maxillofacial prostheses, rather than making the clasp and any other thing. So can you please tell me that if orthodontists have any role to play in maxillofacial prostheses?
Sure. Definitely, sir. Even Pradeep sir is asking a question like, do we have the cleft lip patient? Like, if we have the cleft patients, in those conditions, we need to do the nasoalveolar remodeling. So, to do the nasoalveolar remodeling for those patients, we take the help of the orthodontic colleague.
Yes, thank you. I know that the cleft patients we usually align, we have better role. I think in other specialties of dentistry or any other field, we have a better role, because we have to deal with the patient from very early age, and stage by stage we have to do some sort of work. Rather than cleft, do you have any other field that where I can have any contribution?
If they have the like orthodontic surgery, they can also be performed for the maxillofacial use defect, even orthodontic surgery. If they have the maxillomandibular discrepancy is there, so surgery during the surgery, orthodontist will help a lot. And usually,
sorry for interruption. I want to know about prosthodontics. Any maxillofacial prosthesis after reconstruction, is there any role of any orthodontist in that aspect?
For the construction of the prosthesis, sir?
No. After reconstruction for maxillofacial prosthesis, in that case, do you have any recommendation for any orthodontic work?
So I'm not able to hear your sound properly, sir.
Okay. Thank you anyway. Just I wanted to know if orthodontist has any other role rather than cleft palate or orthodontic surgery in this in this process of maxillofacial prosthesis.
So for the processes till now, I have not worked with orthodontist till now, sir. But the ortho, then in those conditions, the orthodontist will be the better colleague to help us to align the teeth to have the proper prosthetic prognosis, sir.
Okay. Thank you.
Thank you, Dr. Shyam and Dr. Mahmood Sadudin. And Dr. Rajiv Kumar Bonik, can you hear me? Dr. Rajiv Kumar Bonik, can you hear me? So next, now I request our chairperson of today's seminar, Professor Dr. A.K. Mazul Haq, to discuss about today's webinar session and give suggestion and criticize about the session. Also give advice to us for future activities. Professor Aziz, sir.
After the discussion of panel member.
No, it is your discussion. You ending, you scope another second time.
Oh,
You.
yeah. It is very much unfortunate. In replying of the Dr. Uday Goswami asked me to know some query. It is very much unfortunate that no prosthodontist is not posted at Dhaka Medical College till now, where Dr. Uday is working. Here I can say that in Dhaka Dental College Hospital, in every maxillofacial surgery, where there will be maxillofacial defect, at that stage and before surgery, the surgeons, maxillofacial surgeons, ask to the prosthodontist and take the consultation with the prosthodontist about the surgery, about the future maxillofacial prostheses. For Dr. Uday Goswami, I can give advice to you that you can go to the DG office and ask them, the personnel of that is director dental or personnel of DG office, just immediately to be posted for a posting one or more prosthodontists, that is postgraduated in prosthodontics. That will be will helpful for you, as because maxillofacial surgery and maxillofacial prosthesis is a multidisciplinary approach. And today's seminar, Dr. Shyam Maharjan, these topics will say, that is the maxillofacial prosthetic rehabilitation, improving the quality of life. That is, it is that improve the quality of life by functioning, by aesthetic, and by improving and by preventing the psychological stigma or trauma. So, in replying the question of Uday Goswami, I have given this advice. Immediately, you can go to the DG office. I can say that you will be successful. You will be successful to get an prosthodontist for your department, that is Dhaka Medical College. After this, thank you, Dr. Goswami, for arising this type of question and this type of suggestions for me. It's my privilege, and I like to give you thanks for that question. Okay, next.
Thank you. Okay, thank you, Dr. Adit sir. And in our country, burn affected people increase day by day for different type of fire and chemical exposure. So our Prime Minister made a burn and plastic surgeon institute. Dr. Pradeep Das is enlightened plastic surgeon. He do his job in this place very much sincerely and also by various type of surgical intervention. Who posted as an associate professor in Sheikh Hasina Burn and Plastic Surgery Institute. I request Dr. Pradeep Das to discuss about today's session on your point of view and show some cosmetic work those are you have done in your institute. Thanks.
Thank you, moderator Dr. Anupam Poddar, my big senior brother. And at this midnight, I would like to say thanks to all the panelists, especially our senior teacher, Professor Ajil Haq sir, and uh, all the thanks goes to the presenter, Shyam Kaji Maharjan. What I say about your presentation, uh, simply to say that you are doing marvelous job in your country, especially I think in Southeast Asian region. Actually, being a plastic surgeon, I have a very little experience about the boundaries of orthodontic and prosthodontics. Uh, so hopefully, my judgment is in our country. Our departments are also running such jobs, but I am not accustomed with these jobs. Okay, thank you again, Shyam Kaji Maharjan. But I would like to say a few comments or a few uh, uh, experience of my personal experience about the work in this field, especially for maxillectomy and mandibulectomy. The defects created from maxillectomy and mandibulectomy, most of the times, I would like to reconstruct the such defects, especially you saw a few of the big defects created from maxillectomy. In that case, I would like to reconstruct these defects with fibula, especially single barrel or double barrel. Sometimes I do triple barrel. So we can easily take a barrier by the bones, what you mentioned earlier, that we need a bones. And then we can take a huge amount of soft tissue, especially we can take the gracilis muscle, soleus muscles or gastrocnemius muscles, and the large amount of skin pedal as well for both coverage in the oral aspect as well as in the orbital aspects. I have done few cases. So when there is no scope for microvascular reconstruction, there is no alternate for live tissue reconstruction. So if we see that there is no scope sometimes, but I don't feel there is no scope for reconstruction. Especially one problem when arises from vascular insult. So we can recreate vascular channel, especially artery vein, recreate a channel and then go for second stage for reconstruction. But most of the times, patients, when the patients are poor, they are not able to arrange for microvascular surgery, or the surgeon has no, you mentioned it earlier, the surgeon has no the has not the capability to do the microvascular surgery. In that case, there is no alternate for prosthetic replacement. You showed up a few cases about nasal prosthesis, orbital prosthesis, and also of oral prosthesis. In that case, most of the times we can reconstruct. I have done several cases of total nasal reconstruction, and especially congenital ones as well as post-traumatic ones. So, first, I would like to say microvascular surgery creates a horizon for reconstruction. You have a good choice for tissue component, bone, soft tissue, even mucosa. For heart plate defect, you can use the fibula as a prefabricated. We can use the oral mucosa in the first stage, and then second stage, uh, with this oral mucosa, we can take a chip of fibula for to replace the defect in the maxilla. So we can get the mucosal surface on the oral aspect rather than a skin surface for reconstruction of the maxillary defect. Mandibular defect, yet in our country, most of our maxillofacial colleagues also doing a few of cases about total mandible or subtotal mandible excision followed by reconstruction. So to say, uh, Your jobs are outstanding, and I know in your country, Dr. Shankar Manrai, and
Yes, sir.
yes, another plastic surgeon is he's one of the colleague, Kiran Nakarmi. These guys are doing nice microvascular surgeries there. So I think you have communication with these people. Probably you have, and
Yes, sir.
that can help you. Yes, that can help you a lot. Shankar Manrai, I was the trainee colleague with him in Dhaka Medical College. So they are the nice people and they are doing nice jobs. Again, heads up to the Nepal peoples, though who are initially got training in our country, but
Yes,
they
sir.
have advanced a lot. So heads up again. Thank you, Maharjan.
Yes, sir. Dr. Shankar Rai, he is a very good, renowned plastic surgeon in Nepal.
Yeah,
He usually do lot of cleft lip surgery,
I know.
and he work in the Kirtipur hospital where there are a lot of the burn cases, sir. For burn cases and for this cleft lip and palate. He is the one of the pioneers doctors treating these patients.
Dada, Dr. Anupam Purtarda, may I share two slide of palatal reconstruction by local flap? Only two slide.
Okay. Okay. Okay.
Uh, just give
Okay.
me the
Please.
opportunity just to see.
Yes. Okay. You go to options to slash share. Yes.
Yes, I got it. Just a minute. Can you see the picture, please?
No. No.
No.
Yeah,
Start screen share. Dr. Pradeep, start screen share.
I have gone through this.
No. Ask to
Oh,
host, today's host.
Screen share.
He will share it.
yes, it is
Share
shared.
it.
It is
Share it.
shared to me. It is shared to me.
No. Host will share it. Who is the host today's
Just a minute.
webinar?
Screen share.
Okay, it's not possible, but it is a technical problem. I would like to say you the medium-sized and small palatal defects. What we previously our colleagues using palatal obturator. I have experienced dozens of cases when initially we use these obturators rather than reconstruction. There is thinning of the oral mucosa, sometimes erosion of the bones. So in that case, I would like to say, if we go for reconstruction with local flaps like vaccinator myomucosal flap or fem flap, most of the times there is a simple solution. So please be sincere about this prosthetic appliance. If you have any scope for live tissue reconstruction, try to solve it like this way. And if there is no scope or there is no facilities, then go for prosthetic replacement. Thank you, Maharjan.
Yes, sir.
Again, thank you,
So,
everybody.
so regarding this reconstruction in the palatal aspect,
Yeah,
the few cases in my the few cases what I have seen, okay, sir,
yeah,
like
yeah,
during the insurgency, during the Maoist period in Nepal, there are a lot of the gunshot injuries cases, sir. In
yeah,
few gunshot injury in the facial regions, okay, where the palate and the soft palate, those were injured, they were reconstructed with the flap. So those cases are successful. And the few cases I have seen where the reconstruction was done, even in case of the maxillectomy cases, pathological cases are reconstruction was done. And usually in those cases, the reconstruction fails. So I think because while doing the after the total maxillectomy, if we have some support, some basal bone to support the soft tissue, in those conditions, this reconstructions works well. And in case where there is no support of the bone to support the soft tissue, I found in those conditions those soft tissue resides and the defect was created again. And in case of clay pellet also, while in reconstruction was done in many cases. So while doing the approximation of this bone, that will lead that will make the good prognosis of the repair that was done with the flaps.
Right.
Okay, Dr. Pradeep, technical
Yes,
problem
sir.
is solved. If you try to slide share, technical
Just a
problem
minute.
already solved. Okay.
Yes, I would like to share. Apply both through. Just a minute. But my Dada,
Hmm.
It is not
my
working.
window is not supporting. My window is not supporting.
Yeah, yeah.
No sound. Okay.
Okay, later.
Okay. Thank you,
Thank
Dr.
you.
Pradeep and Dr. Shyam. Now, as a maxillofacial prosthodontist, Dr. Ashikul Wadud, who completed his BDS from University Dental College and take diploma on maxillofacial prosthesis in Mahidol University, Thailand, and do job as a assistant professor, Department of Prosthodontics in a well-equipped academic environmental space of our country, Update Dental College. I request Dr. Ashikul Wadud please add a few words, and if you any query, ask to speaker or Dr. Shyam Kaji Maharjan.
Thank you, Anupam sir. Actually, as a maxillofacial prosthodontics, I don't have any scope to judge any other my colleagues as a maxillofacial prosthodontics, as because maxillofacial prosthodontics is very differ from case to case, and it's vary from person to person, and it's vary from the prosthodontic aspects of every prosthodontics. So in that case, the work is very done properly in Nepal by Dr. Shyam Kaji Maharjan. I congratulate you. It's a very wonderful job you've done over there in Nepal. And the thing is, I guess with the due respect with the Pradeep sir, he told about like we can close the defect with some soft graft. Actually, sir, we can close, but sometimes we have some problem with phonation, and sometimes we have some problem with the speech evaluation of the patient. So that's time, sir, we need some defect as a maxillofacial prosthodontics to improve the phonation of the patient, also improve the retention of the prosthesis. So in that case, sometimes when I was in Thailand for my MSc and diploma, that time I heard like sometimes our teachers ask to surgeon to keep the defect over there. So they will use the defect and they will modeling the defect, and then they will create the good prosthesis over there, and the retention will be very good in that defect cases. And in case of total maxillectomy cases, yes, I have done some cases. In that time, we are using like a maxilla obturator, but it's two piece. So the one piece is for the closing the defect, and another piece is the complete denture. So it's attached with sometimes magnet, or sometimes we attached with some other components like the ERA components and something other resilience attachment. So this is like a vary from person to person. And as a maxillofacial prosthodontics, the field is very vast. And in our country, of course, with the due respect with the Ajit sir, that we need maxillofacial prosthodontics in every dental college or dental institute, or any in with the maxillofacial surgeons, as because surgeons do their job very accurately. They save the life of the patients, but sometimes after saving the life, they don't get the proper rehabilitation, they don't get the proper prosthesis, and they lost their mind, they lost their happiness, and they lost the acceptance to the society. So it's very painful for them. So we need maxillofacial prosthodontics we have to establish the maxillofacial prosthodontics in Bangladesh in well cubed. And Nafis is also is my batchmate, is my friend, and he can also help us to build a bridge work with Malaysia, Bangladesh, and also Shyam Kaji Maharjan also help us from the Nepal. And we can make a very good center over here in Bangladesh. We have a lot of cases over here in Bangladesh. So I am requesting our chief guest, Professor Ajit Saiki sir, to enhance the maxillofacial prosthodontics field in Bangladesh. And we have to develop this one, and we want to work together. That's my opinion. Thank you.
Thank you, Dr. Ashik Wadud. Dr. Oshim Kumar Saha, can you hear me? Dr. Oshim Kumar Saha, can you hear me? Dr. Rajiv Kumar Bonik, can you hear me? Dr. Rajiv Kumar Bonik, can you hear me? Dr. Riyad Mahmood, can you hear me? Now, Dr. Nafis is a star in maxillofacial prosthesis in Malaysia as well as in our country, who completed his BDS degree from Bangladesh Dental College and diploma from Mahidol University, Thailand. Now he is posted as a senior lecturer in maxillofacial prosthodontics department, University of Science, Malaysia. He is also a great researcher. He has many publications. I hope he will give some extra knowledge about today's session that enriched our session. I request to Dr. Nafis bin Jamait to deliver your speech about the session.
Thank you, Dada. First of all, honorable chair of the session today, Professor Dr. A.K. Majizul Haq sir, and honorable coordinator Dr. Anupam Da, and my other fellow colleagues. And I would like to give my congratulations to our today's presenter, Dr. Shyam Maharjan, for your excellent presentation. I hope you guys can hear me, right? Actually, we have discussed so many matters, so I will not go into the details of those. I just would like to say that, you know, when I started maxillofacial prosthetics back in 2010, and today is 2020, I had an opportunity to work in 3 different countries. One is my motherland, which is Bangladesh. Then I worked at Thailand. Now I'm working in Malaysia for the last 7-8 years. And every occasion, what I have seen that what kind of cases are most common that as a maxillofacial prosthodontist we have to treat. In my 10 years and 11 years of journey, let me tell you very frankly, the most common cases are maxillectomy, mandibulectomy, but more than maxillectomy and mandibulectomy, I did myself ocular prosthesis, right? The eye prosthesis. If you go to Bangladesh, even you go to Nepal, and the people who usually refer the cases to maxillofacial prosthodontists, like oculoplastic surgeon, otolaryngologist, right, or oral and maxillofacial surgeon, if they know that a certified maxillofacial prosthodontist is there, definitely the amount of cases that you will be receiving, the highest number of cases will be either maxillectomy case or ocular defect or mandibular defect. This number can be vary, but these 3 will be in the top. So we have discussed a lot about mandibulectomy and maxillectomy because surgeons are involved here. They talk about flap and all those things. We talk about obturators and all those things. I would like to talk about, hello? Is it audible now?
Yes, sir.
Okay. I would like to talk about more on extraoral prosthesis, the ocular prosthesis or orbital prosthesis, more on the ocular prosthesis, because it is more aesthetics and it is quite challenging. I feel personally that in order to have a successful rehabilitation for maxillofacial prosthesis, the first thing is the proper communication, and the communication with the people who usually refer the cases to us, especially the surgeon. Like different surgeons, they want to rehabilitate according to their wish, right? They want to flap it, they want to reconstruct it, because surgeons are very skillful and they want to apply their skill, right? But when it comes to the multidisciplinary approach, I believe that we need to sit together before proceed to any case, right? And we have to ask ourselves that what is our goal and what is our target, aesthetic or function. Then the team which is comprises of all the disciplinary people like speech specialist, maxillofacial prosthodontist, surgeon, orthodontist, right? So we need to have a proper planning. So if we have a lack of communication, I have seen in my career that a lack of proper communication is ruining your cases, is damaging your cases in so badly that you cannot reverse. So I would like to emphasize more on this matter, that since we have a multidisciplinary people right now presented in same window, we have plastic surgery specialist, we have oral and maxillofacial surgery, we have orthodontist, we have maxillofacial prosthodontist. We need to communicate properly and sincerely before we proceed to any case, because here to rehabilitate, we are talking about rehabilitation, right? One is you remove the cancer, second is rehabilitations. So in certain extent, scientific article, scientific report suggested that in certain extents we can go until surgical rehabilitations, and there are some extents that we have to go for the prosthetic rehabilitation. This is one thing. So meaning that I want to summarize proper communication between multidisciplinary people. This is one thing. Second thing, this is I'm more interested to discuss in a very short while. I felt myself, country like Bangladesh, country like Nepal or India or Pakistan, what I mean to say that the developing country, right? We are developing country. We are still not yet to be reached into the developed level. When we want to, establish or we want to develop a subspecialty, something like orthogontic surgery, something like microvascular surgery. Yeah. So I'm talking about the subspecialty. It's very challenging. It is very challenging, and Dr. Shyam Maharjan, what you have done until now, it's quite excellent. I faced a lot of challenge when I was about to start this maxillofacial prostho in Bangladesh, because the people has a very lack of informations. So I would like to give special vote of thanks to the people of basic dental school bond and other people in other groups, in other Facebook whatsoever, that they are promoting this subspecialty. Also, these days dentistry in some countries are more into the general dental practice. People are more thinking about endo, oral and maxillofacial surgeries, but these are the subspecialties that we need to develop. Because if you go to the community, right, and if you search for the patient, if you tell the surgeon, right, that I'm a maxillofacial prosthodontist, I have a capacity to rehabilitate these cases, you will have thousands you'll be flooded with the patient when the referral starts. When surgeon know that I have a guy who can rehabilitate the case, surgeon will flood you with the cases. I have seen this in my career, both in Bangladesh, Thailand, in Malaysia. I have done more than 500 ocular prostheses in my own hand in Malaysia. Before I arrived, they said that we did not see any ocular prosthesis cases. The cases are there in the community. The surgeons are ready to refer, but they do not know the people are there. So I would like to give a special thanks to all these people, that we need to promote this subspecialist field. Dentistry is just not about the canal. Dentistry is not about the reamer file. Dentistry is something very much beyond, right? Very much beyond. Our juniors, they do not know, they do not believe, but our field is more than that. More than that. We can change it. When somebody has a defect, they do not have any relation with their family member. They cannot go out to the community. They do not participate in their work in the social activities. When we give prosthesis to somebody, that particular people started building a relationship with their family member. They go out to the home, they mix themselves into the community. At the end of the day, what happened? We bring these disabled people into the country's economy, let them play their role into build up the economy of the country. That's we do, right? But as a dentist, most of our junior, our younger generation, they just believe that dentistry is just about extraction, root canal, No, this is beyond. So I'd like to give a special thanks to Dr. Shyam for your excellent presentation, that people are, people have seen that what you have done, what you are doing in Nepal, right? Exactly what you are doing, man, we are doing the same thing in Malaysia. There is no such difference. So I'd like to say, before ending my speech, two things. First thing is that maxillofacial rehabilitation is about a teamwork, and everybody has to, meet together to set a common goal and to help each other to reach that goal. This is one thing. Nobody is a single hero here. Everybody has to play their role equally if you want to make a case successfully. And second thing is that if you really want to develop this one in a country like Bangladesh, India, Pakistan, I mean the developing country, we need to work together, and inshallah, this journey will be continued. Thank you very much.
Thank you, Dr. Nafid, for your nice discussion. And before the ending of the session, there is a question. Dr. Uday Goswami, can you hear me? Dr. Uday Goswami, you have a question from Dr. Rajiv Boni. What should be the referral protocol for maxillofacial prosthesis before surgery? What should be the referral protocol for maxillofacial prosthesis before surgery? Question from Dr. Rajiv Boni.
उदय गोस्वामी अनम्यूट करे ना प्लीज अनम्यूट योर माइक
Unmute.
Oh, sorry. Dr. Rajiv, thank you for asking this question. And the referral protocol is as usual. When we refer any patient to other department before going to surgery, we have to refer this patient in maxillofacial prosthodontist for their planning. We will inform them that what we will going to do, and they will give us the operator according to the multidisciplinary discussion, which have been discussed here previously, that we have to discuss before the surgery or before our surgery. In case of maxillofacial malignancy, in case of any carcinoma or any other malignancy in orofacial region, we have to discuss before surgery with maxillofacial prosthodontist, surgeon, if needed, plastic surgeon, and then we have to prepare the protocol before going to surgery. And this is the referral protocol. I think Rajiv can understand it. Okay, I want to add something. Dr. Anupam Dada, I want to add something. In response to our plastic surgeon, Dr. P.C. Dash.
Yeah.
He mentioned that the microvascular surgery is the prime role in case of maxillofacial surgery reconstruction. I want to say that in sometimes when we do any maxillectomy or mandibulectomy, we will provide a biological structure like bone, microvascular bone, or microvascular tissue. In that case, we have to face some problem, and such type of problem is MPDAS. That means myofascial pain dysfunction syndrome. Myofascial pain dysfunction syndrome can produce due to improper occlusion. That means malocclusion. And in that case, maxillofacial prosthodontist has the prime and vital role to provide the proper occlusion of that patient, so that that patient can masticate properly, and he can get relief from myofascial pain dysfunction syndrome.
Okay.
Thank you.
Thank you, Dr. Rajiv, can you hear me? Dr. Rajiv, can you hear me? Dr. Riyad, can you hear me? Dr. Riyad, can you hear me?
Dada,
Now
I would like
the
to, Dada, I just would like to add with Dr. Uday Goswami. I am totally agreed with him. I just want to share small of few of my initial days experiences. What happened is that, you know, what are the consequences of, you know, when you have a lack of communication with the surgeon? I give you one example. You know, when we have mandibulectomy defect cases, if like a partial hemimandibulectomy or segmental or whatever, right? So if you do not have a good communication with the surgeon will suture back the mucosa in their own design, right? So what will happen is that when case is referred to your clinic, in the maxillofacial prosthodontist clinic, and they want to take a impression or they want to fabricate a denture, they don't see that there is a very lack of space for the vestibular sulcus where we'll get the support for the denture flange, right? We want a good sulcus. So before proceed to any kind of case, if a maxillofacial prosthodontist and surgeon have a meeting together, if we can do a small, you know, model design or model surgery sort of thing. So we have a chance to say, where we have a chance to mention them that yes, we need these areas some sulcus. So according to that, surgeon can, you know, do the vestibuloplasty and other things, right? So we'll have a support area available for our denture flange. This is one example. This is about the intraoral cases, right? Like similarly for extraoral cases, when we do a lot of ocular prostheses, we do not have sufficient volume left there because of surgeon doesn't know that how much space I need in order to put ocular prosthesis into the socket. So it is always better to have a communication prior, you know, start the procedures before performing the surgery. So the oculoplastic surgeon would know that there will be a prosthesis there and it needs at least 3 to 4 millimeter thickness of area, something like this. So the communication is very much important here. Thank you, Dada.
So to add with this, like I have also the few experience where we have the miscommunications, like for the immediate, even for the immediate surgical obturators, we patient will refer to us, we make the impression, and we ask the surgeon to mark the line for the dissection. Okay, so the surgeon mark the line for dissection. They plan like for the to extend the lesion to the lateral incisors, and sometimes they at the time of surgery they will extend till the canine regions, and they will complain us like the this obturator are not fitting in those cases. So if we have the proper communication, the fitting of the obturator will be easy. And regarding this graft closures, like in one case, what happens was the defect was completely closed with the graft, and it was referred to us for the prosthetic rehabilitation. But defect was closed in such a way that there was no space for the restorations. The flap was there, so we cannot take the support of the flap. We cannot take. We have no any areas to take the support or to extend the flange of the prosthesis. So in that case also the prosthetic rehabilitation becomes the failure. We are not able to rehabilitate the case with the prosthesis. Patient has to sit without prosthesis with the defect closed with the graft.
Dr. Shyam,
Thank you.
Sir, Dr. Shyam, we have to also, you know, because many people have this question, right? In Nepal and in Bangladesh also, when we do ear prosthesis or orbital prosthesis, they have a question how it retains. So in Nepal currently, what kind of retention? If you said that implant is a we do not have sufficient amount of implant, extraoral implant, and it's expensive. So what kind of glue you are using right now at your place? What kind of adhesive system you are using?
In Nepal, no silicone adhesives are not available easily. So I think two of my cases I did with the silicone adhesive, because when we went to the conference in India, we bought silicone Durabond. I think Durabond. We bought Durabond from India, and we did two cases. So in most of the cases for the orbital prosthesis, we used to get the retention, if possible, from the undercut. If there is an adequate undercut, we used to fabricate the silicone prosthesis so that it is easy to engage in the undercut. If not, then we are fabricating the spec retained orbital prosthesis. So that will be mechanically retained, and it